Physical Examination of the Knee Joint, Learning Contract 3 by Emily Coulthard-Jones. The knee is one of the more commonly injured joints, especially in running and jumping sports. The knee takes a lot of stress, especially when bending. Studies have shown that the forces at the knee joint can reach 3 times body weight when the knee is bent during activities, such as going upstairs, and up to 6 to 7 times more body weight when in a full squatting position. Internal derangement of the knee refers to a variety of damaged structures that can be injured within the knee, including meniscal cartilage tears and loose bodies. Observation. When the patient first walks into the examination room, their gait should flow in a smooth, rhythmic motion. Have the patient wearing appropriate clothes for the examination. If the knees are slightly flexed and the patient cannot straighten them, it may indicate a pathology, particularly if the flexion is unilateral. The examination of the knee should include an assessment of both posture and lower extremity alignment. The alignment of the knees can be quickly screened by having the patient stand with their ankles together and observing their knees. Have the patient standing. Ask them to march up and down on the spot first to make sure they assume their normal stance. Look at the levels of the patella, muscles and bony landmarks, looking for symmetry or asymmetry. Observe for gena varum or bow-legged, gena valgum or knock knees, and gena recurvatum, which is hyperextension of the knees. When looking at the patient with both feet together and pointing forward, if the kneecaps point inwards, they have what we call squinting patella, which often represents a rotational malalignment at the hips called femoral anteversion, where the hips are angled such that the knees and lower leg rotate inwards. It is important to always check the hip joint when evaluating knee injuries, because the hip may refer pain to the knee. Look for any swelling which could either be localized, indicating a bursa, or generalized, which indicates intra-articular inflammation. The knee may be flexed to accommodate for the swelling. You can ask the patient to tense their quadriceps, which should cause the knee joint and patella to become more prominent. If it doesn't, then this could show some swelling. To check for any swelling, you can use the sweep test. The sweep test tests small effusion. Empty the medial joint recess using a wiping motion. This milks any fluid into the lateral joint recess. Now do a similar wiping motion to the lateral recess. Watch the medial recess. If fluid is present, a bulge will appear on the medial recess. Palpation. Have the patient sat on the edge of the bed. Their knee is more accessible here. Sit on a chair opposite and anchor their foot or lower leg between your knees, leaving both hands free for palpation. Having their knees at 90 degrees means the skin is more taut, but the muscles, tendons and ligaments are lax, meaning palpation is much easier. Palpate the joint line by placing your hands around the knee, using your thumbs to press into the soft tissue depressions on the anteromedial aspect, just lateral and medial to the infrapatellar tendon. Feel for all the bony landmarks around the knee, such as the tibial tubercle, the femoral condyles and epicondyles, the tibial plateau, the head of the fibula and the patella. During palpation, you should be trying to feel for any abnormalities, for example heat from inflammation. You should also note down any tender areas that are reproduced from palpation. There are 4 clinical zones of soft tissue palpation for the knee: the anterior, medial, lateral and posterior aspects. Feel for any defects or ruptures. Feel for any swelling of the bursa, the most common being the superficial infrapatellar bursa, the prepatellar bursa and the pes anserine bursa. Feel for tenderness around the menisci, i.e. medial of the knee for medial meniscus. Also feel into the popliteus fossa and palpate for the popliteal artery pulse. Active range of movement highlights whether or not there are any gross restriction in a patient's range of knee motion. To assess knee flexion, ask the patient to squat in a deep knee bend as far as they are comfortable. They should be able to flex both knees symmetrically. Ask the patient to stand up from the squatting position for extension, and take careful notice of whether they are able to stand straight, which knees in full extension, or whether one leg is more relied on than the other during the procedure. Or have the patient sat on the end of the bed and ask them to straighten their leg. This movement should be smooth, and if the patient can't fully extend the knee, it usually means they have weakness in the quadriceps. For internal and external rotation, have the patient flex their knee and rotate the foot medially and laterally. Ranges of movement. The patient can be prone, supine or sat at the edge of the table. For the purpose of this video, I am going to have the patient lying supine. Again, start with the non-symptomatic knee. Grasp the knee at the knee joint with your cephalic hand and the caudad hand holding the ankle. Then, flex the knee as far as it will go, noticing the distance between the heel and the buttock. In a non-symptomatic adult, the knee should flex to around 135 degrees. Repeat this process with both knees and compare. This end field should feel soft. Next, slowly take the knee into extension. This movement should be smooth and you should go to at least 8 degrees or beyond and into a few degrees of hyperextension. For internal and external rotation, maintain your hand position on the patient's knee and place your caudad hand on the sole of their foot, using the foot to rotate the tibia. Palpate the joint line and the tibial tubercle. Accessory movements. The patella. Assess the range of movement of the patella by moving it superiorly, inferiorly, lateral glide, medial glide, internal and external rotation, distraction and compression. Compare with the other patella. Any tilting or rotation of the patella when it is pushed medially or laterally should also be noted. If the medial structures are too tight, the patella will tilt up when pushed laterally. If the lateral structures are too tight, the patella will tilt up when pushed medially. Fibular head. Move the fibular head in a anterior-posterior direction and then in a posterior-anterior direction, comparing with the other side. Special tests. For all special tests, they should be carried out on both knees for comparison, but for the purpose of this video I will just demonstrate on one knee. I have come up with some of the most common and most used special tests for the knee for the sake of this video. It is not a comprehensive list. McMurray's test. Tests the medial meniscus and lateral meniscus. Have the patient supine with the test knee completely flexed and the hip flexed. To test the lateral meniscus, provide a varus stress on the knee and internally rotate the leg while passively extending the knee. To test the medial meniscus, repeat this but with the leg in external rotation with a valgus stress when the knee is extended. If positive, there should be a pop or a click with possible reproduction of pain. The patellofemoral grind test. This tests problems at the patellofemoral joint. Have the patient supine with the knee extended. Pinch the patella on either side with both hands and gradually compress the patella, moving it inferiorly and superiorly. If the test is positive, reproduction of the patient's pain will be found, or apprehension. Apprehension test for the patella. This tests patella subluxation or dislocation. Have the patient supine with their knee over your knee in 30 degrees of flexion with the quads relaxed. Passively glide the patella laterally. If the test is positive, the patient will be apprehensive or there will be excessive movement. Valgus or abduction test. With the knee fully extended, this tests the cruciate ligaments, the lateral gastrocnemius, the lateral collateral ligament, the arcuate popliteus complex, the posterolateral capsule, iliotibial band, and the biceps femoris tendon. With the knee at 20 to 30 degrees of flexion, this tests the lateral collateral ligament, the arcuate popliteus complex, the posterolateral capsule, the iliotibial band, and the biceps femoris tendon. Have the patient supine, stabilise their ankle, and apply lateral pressure or a varus stress to the knee at 0 degrees and then again at 20 to 30 degrees of flexion. If the test is positive, there will be excessive movement compared to the opposite knee. Varus or adduction test. When the knee is in full extension, this tests the anterior cruciate ligament, the medial quadriceps expansion, the semimembranosus muscle, medial collateral ligament, posterior oblique ligament, posterior cruciate ligament, and posterior medial capsule. With the knee at 20 to 30 degrees of flexion, this tests the medial collateral ligament, the posterior oblique ligament, the posterior cruciate ligament, and the posterior medial capsule. Have the patient supine and stabilise their ankle, applying medial pressure or a valgus stress to the knee joint at 0 degrees and then at 20 to 30 degrees of flexion. If the test is positive, there will be excessive movement compared with the opposite knee. Posterior draw test. This tests the posterior cruciate ligament, the arcuate popliteus complex, the posterior oblique ligament, and the anterior cruciate ligament. Have the patient supine with their hips flexed at 45 degrees and the knee flexed to 90 degrees. Stabilize the foot by sitting on just the toes and apply an antero-posterior force to the tibia. If the test is positive, there will be excessive movement in comparison to the other knee. The anterior draw test. This tests the anterior cruciate ligament, posterior oblique ligament, arcuate popliteus complex, the posterior medial and posterior lateral capsules, the medial collateral ligament, and the iliotibial band. Have the patient supine with the hips flexed at 45 degrees and the knees at 90 degrees. Stabilize the foot by sitting on just the toes and apply a posterior-anterior force to the tibia. If the test is positive, the tibia moves more than 6 mm on the femur. Latchman's test. The Latchman test is a clinical test used to diagnose injury of the anterior cruciate ligament, or ACL. The knee is flexed at 20 to 30 degrees with the patient supine. The examiner should place one hand behind the tibia and the other grasping the patient's thigh. The tibia is pulled forward to assess the amount of anterior motion of the tibia in comparison to the femur. If positive, the knee will demonstrate increased forward translation without a decisive endpoint, a soft or mushy feel indicative of a positive test. External rotation recurvatum test. This tests the posterolateral rotatory stability in knee extension. Have the patient supine, hold the heel and place the knee at 0 degrees flexion. Slowly extend the knee while palpating the posterolateral aspect of the knee. If the test is positive, there will be excessive hyperextension and lateral rotation palpated. Apley's compression and distraction test. For distraction, this tests ligamentous injury, and for compression, this tests meniscus injury. Have the patient prone with their knee flexed at 90 degrees. Medially and laterally rotate the tibia with compression and distraction. If the test is positive, it will reproduce pain. Thessaly's test. This functionally tests meniscus tears in the standing position. Since bending and twisting movements while weight bearing often reproduce pain from meniscus tears, this test recreates the exacerbating movements. Have the patient stand on one foot with their foot flat on the floor. Hold the patient's hand for support and have them initially bend on the standing knee to 5 degrees of flexion. Ask the patient to twist at the knee, making sure they are internally and externally rotating at the knee rather than at the pelvis or the back. Check for any reproduction of pain symptoms. Next, have the patient bend the knee deeper to 20 degrees and again actively twist on the knee. If this is positive, the twisting movement will reproduce pain of a meniscal injury. The pain is typically localized to the joint line, and patients have more pain on the knee bent at 20 degrees rather than 5 degrees.